wanted to introduce Dr. Priscilia Brailsford as our keynote speaker today. And she's going to be talking about transcending trauma. Do you want to switch the promoting resilience and coping with after loss. Dr. Brailsford is a chairwoman and professor in the International Psychology program at the Chicago School of Professional Psychology. She studies the effect of trauma and other stressful events, especially on the effects of these events on those from historically oppressed and stigmatized groups. Dr. Brailsford has several ongoing research projects on ethno-cultural violence, community violence, and disasters. Her presentation today will review innovative models for effective trauma treatment and crisis interventions. Participants will gain an understanding of the short and long-term consequences of traumatic events and develop skills in managing reactions and practicing self-care strategies. So welcome.
Good morning, everyone, and thanks for coming today. Thank you, Mary, for the welcome. It's a real honor to be here today. So the objectives of today is to understand how individuals can be empowered and guided to resiliency in the aftermath of trauma. John mentioned a lot about resiliency. I really like the way you described it. One of the reasons I am so attracted to trauma work, I mean, I've studied all the other different mental health issues, but people who have PTSD are usually my favorite patients. Because I always say that people who have PTSD, there's nothing wrong with them. It's about something that happened to them, right? Unless the person has had past or historical, mental health pathology or whatever. But most of the people I see come in wounded and hurt and suffering, and they leave empowered and strengthened. And you can do that with someone who has PTSD. It's very, very possible. Resiliency, post-traumatic growth are realities for people who are wounded by traumatic events. To gain an understanding of the short and long-term consequences of trauma, to review innovative, culturally appropriate models for effective trauma treatment, and to develop skills in managing your reactions and practicing self-care. So that's the objectives of today's presentation. So what is trauma? So those of us in the clinical world use the DSM-5, the Diagnostic Statistical Manual, because we have to give people a diagnosis in order to build insurance. And I just took out the snippet here from it, which is directly experiencing a traumatic event, witnessing an event, hearing about an event that occurred to a close family member or a friend. Okay, and the last part is really important because many of us who work in the helping professions may not directly be at the traumatic event, but just hearing about it can be very traumatizing. So for the clinicians in the room, every time you engage with someone who has had a trauma and you hear about their trauma, you are really getting traumatized yourself. And the scary thing about hearing about a trauma is because you were not there, our mind imagines things worse than they really are. There has been research done on this, by the way. Okay? Whereas people who directly witness it, their potential for becoming resilient is greater because they actually saw what happened. They don't have to make things up. This is another definition from the National Office of Victims Assistance that I've always been using, and I like it. Events that are traumatic to most individuals are unexpected, random, or arbitrary. And the arbitrary part is important, right? Because someone can lose a child or a partner and be traumatized, and someone can lose a pet and just as well be traumatized. So we can't use any judgment on who gets traumatized or who's affected more than others. Okay, that is usually an arbitrary issue. They are life-threatening, take away individual autonomy, and cause significant loss to an individual. So in order for it to be traumatic, so I'm using the word a lot and loosely, I know, but it takes a lot to be able to do this. You have to be someone who's not going to be able to go to work the next day, and you can't carry on with your life. So, or you feel like you can't carry on with your life. I should have said that I actually like questions while I'm speaking, so if there's something I say, there will be time at the end for questions as well. But if there's something I'm saying that you don't understand, please raise your hand. It doesn't interfere with the flow of my presentation, okay? But I'd rather explain it at the moment rather than wait till the end. Yes?
Looking at the NOVA definition, if we include in the definition individual autonomy is taken away, doesn't that then beg the question that the person would lose resiliency? And maybe that might not be a good definition?
Right, and no, that's why it becomes traumatic, because the person loses autonomy. That's why it's traumatic. But you can get it restored. That's the resiliency part. Okay. So good question, yeah. And that's why self-care and practicing behavioral changes becomes really important in therapy. The other thing as well, Mary had mentioned that listening to this material can be very difficult, right? And your memories, might go back to 9/11, 2001, right? I don't know where you would have been on that day. So just remember that all that is going to be happening. So predict and prepare yourselves. Make sure that you breathe while I'm talking. Make sure you drink a lot of water today. Water can be very hydrating. What happens is when people listen to traumatic stories, you begin to breathe from your throat instead of deep down. Okay, because your body goes into that sort of mode, right? Frozen. So please remember to breathe and to relax as you listen. So post-traumatic stress disorder, this is now an official designation in the DSM. It's one of the most common mental health problems observed post-disaster. The prevalence rates are 30 to 40% among direct victims, 10 to 20 among rescue workers, and 5 to 10 among the general population. So you can see how high it is post-disaster, whereas for the general population, it's about 5 to 10%. Most of the people I see in my clinical practice are in the 5 to 10% range. And people think, oh, you're a trauma psychologist, you must be seeing a lot of people with PTSD. That is actually not true. In order to get the diagnosis of PTSD, a lot of criteria have to be met. So in my over 15 years of doing this work, I may have diagnosed people with PTSD, less than on my two hands. So it's not as common among the general population.
Whose study is that, 10 to 20?
These are all CDC estimates, Center for Disease Control.
I think 10 to 20 is low.
No, but that's the general population.
No, for responders.
Oh, for responders, yeah.
That's low.
Right, but remember they take the average?
Yeah.
So I'm sure here in New York City it must be much, much higher.
Yeah.
That's the problem with research, right? They generalize and they use averages.
There's 2 million law enforcement across the country. So as we speak, there's a cop getting into a car accident or in a shootout that's going to eventually be diagnosed.
Right.
I just think it's going to evolve, just from what I see.
Right. And I agree. Yes.
Just to make a comment on that. So I'm a researcher at Columbia, and we've done research on exactly this. I'm sorry, I'll try to speak up. We've done research on exactly this subject, and there's a couple of problems. One of them is there is resilience as a factor, and so lots of people experience trauma, and so there are many people who experience trauma and don't actually develop post-traumatic stress, although they certainly can have symptoms or other effects. But on the other hand, with rescue workers and first responders, there's a lot of underreporting. And if you look at some of the, which I'm sure doesn't surprise you, and if you look at some of the longitudinal data, whereas for most populations the rates of PTSD goes down, among rescue workers it goes up. And one of the reasons for that may be that over time they may be more willing to speak about those symptoms or endorse them.
But keep in mind, a police officer or a firefighter that has 17 or 18 years on the job and wants to get to their 20-year pension is not going to report that, they've been seeing somebody on the side or whatever the case may be, because they don't want the department or the city to know.
Yeah, I see a lot of people like that in DC that do not want that to be on their record. And so you're right, underreporting is probably a big one, yes.
I'm also a retired police officer and a 9/11 responder myself, and I'd love to know what the statistic is for, as John just said, the post-retirement. It doesn't have to be 20 years, but what's the post-retirement number when you're looking at a PTSD diagnosis? Because I hear it all day long. So I represent people who were sick from 9/11, and there's this, there's a lot going on with the when is it my turn to start with. That's the biggest PTSD issue that exists right now that I see in the community. But on the other side of that is what will happen is people will retire, and they rely heavily on the health program, not on the job, because the job scares you if you tell them you have PTSD. But they rely heavily on the health program. And I have people who literally put their papers in, they retire, and they go to the health program the following week and they get certified for PTSD. Because that's pervasive in all first responder jobs, is the fear of what's going to happen to you. Not even so much the labeling anymore, but just the fear if they're going to create an issue for your job. As a researcher, I'd love to know what the statistics are on post-retirement, whether it's a post-retirement issue after 20 years, or if it's somebody who's up with a disability who suffers from 9/11 related cancer, then retires, then goes through it as well. I think it provides a really fascinating, or even in the civilian survivors, when they leave their job and they're out on a disability. There's plenty of people who work downtown, plenty of people who work in the towers that then could no longer work. But then there were people who did work. So the people who did work, once they finally retired, did they then go on to get diagnosed with PTSD after that because it may have affected their employment?
And a lot of this is very political, because in order for someone to get PTSD on the job, someone has to pay, right? Look at what happened with people in combat. It took so long for that to be an allowable disability, right?
John would be better to talk about the military.
Right, no, we should move on because that's not
Talk about the military.
yeah. But it's interesting because they were just not giving soldiers PTSD, even though their whole job was about PTSD.
I just want to confirm with the Joe research, 50% of my clientele are 9/11 first responders. And I've been working with police officers for over 30 years. But all of my police officers, World Trade Center, did not report anything about any kind of mental disability or trauma until after they retired, because they were afraid for their job. Right.
Or having their guns taken.
Yes, right. They're not-
So yeah, it's good points. Yes. So comorbidity. Okay, PTSD is one of the most common, of course, mental health effects, but there are a lot of other comorbidities with PTSD. Even when you look at anxiety and depression, a lot of the symptoms overlap. The difficulty sleeping, the issues with appetite, the loss of energy, those are all depressive symptoms, but they can also be PTSD symptoms, okay? And non-specific psychological distress and health concerns always increase, and increase in substance abuse, because substance abuse in some ways is a socially acceptable coping mechanism. Not substance abuse, but substance use, I should correct, okay? It's socially acceptable that we have a glass of wine, right? Right? And then it becomes a bottle, right? That's the abuse part, exactly. But there are some things in society that we, turn a blind eye to until it becomes an issue, and I'll come to that a little later. So in terms of reactions to trauma, and you'll notice I use the word reactions and not symptoms in order not to pathologize, right? Because it's actually very normal to have reactions to a traumatic event. If you didn't have any reactions, then I'd be concerned about what's going on, right? That you don't have any reaction. So it's very, very normal to remember that these reactions fall in 5 areas. Physical, basically in our body. So change in sleep patterns, that's one of the reactions that we'll notice very early on. Now, North Americans in general have sleep issues. I mean, the morning shows, magazines, you'll see that Americans don't sleep well and all of that, very evident. But after a trauma, sleep can get very, very impacted. Okay, difficulty. Some people oversleep. That's one of the common ones. They just don't want to get up, and some people just cannot fall off to sleep, or will have frequent awakenings, nightmares, night terrors, like something's happening all over again. Change in appetite. Some people overeat. Some people don't want to eat at all. After 9/11. The sales of junk food like chips and ice cream and chocolate went sky high. Because what were people doing? They were trying to nurture themselves with comfort food and watch television the whole time. Okay? So appetite issues is another one. Headaches, migraines, all that stuff, fatigue, energy, the breathing, muscle tension. Sometimes people just forget that they're holding themselves almost in that alarm state that I'll come to in a little bit. And sweating and stomach upset, very common. Then it's psychological reactions, the way we feel, okay, that gets affected. The shock and numbness is the immediate reaction. People just don't know what to say or do. I do a lot of workplace trauma, and on Monday I went into a law firm in the area, near where I live, and when I was asking people, it's actually the wrong time to go in and do an intervention, but whoever decided I needed to be there, I was there. Because people had no reactions. They said they just shocked and they don't know what to say, right? When you just get news that someone died, you don't have words for it. The body has to internalize that and process it before the words can come, right? And yet we require people to use words to describe what happened, right? The fallacy of the way we do interventions. For a rape victim, for example, after a rape, when they are asked to describe who the person is, the words are not there. They can smell the person's breath. They can feel the person's hands, but they don't have the words to describe it, because it's the body remembers, not the cognitive, the processing part happens, secondarily. So depression, sadness, all these other feelings can be very evident in the aftermath of trauma, right? The increased sense of vulnerability, the loneliness, helplessness. People will often think that this only happened to me. I'm the only one that this happened to, right? That's very common. That's why having groups for trauma survivors works so well, because they feel less alone. But again, with all these things, timing is important, because I remember very early in my career, I was trying to send a rape victim to a group, and she saw it as a snub. She said, "Oh, why, don't you want to see me?" And I said, "No, I'm going to see you, but I thought that you could also, go to a group." And she was quite upset at that, and she says, no, I'm not ready to talk to other people. And 3 months later, she was still seeing me. Fortunately, she stayed in therapy, but 3 months later, she did ask for the group. So again, it speaks to the timing of when we do things. Okay, and then emotional roller coaster, right? People, one day they feel up, another day down, right? Emotional roller coaster. And people around the person that's in pain don't understand this, right? They want someone to be on an even keel. That's why some of these reactions, it's really important to share it with people around you, to let them know, this is how I'm going to be feeling, because this happened to me. I have a handout that I give my clients so that they can share it with people close to them. Cognitive reactions, the way we think, right? I mentioned earlier, in the aftermath, people will give you forms to sign. Fill out these forms so you can apply for this and that. People are in no way able to do that, right? I myself, when a police officer stops me because I was speeding, not that I speed a lot, but I can't even find my license. It's in my wallet, and I just can't find it because I get so nervous. It's a crisis for me at that point. So important to remember that it's really, really hard to think straight when you suddenly in a crisis. Okay, and then the confusion. Perseveration is another one that's fairly common, and people really struggle with that. Perseveration meaning you're thinking about the same thing over and over again. And sometimes thinking, what if I didn't do this? What if I did that? What if I didn't go to work today? And there were so many stories after 9/11 around this. I mean, you've probably heard them all. The one that stuck for me was of this guy that got delayed at a doctor's office. He had a doctor's appointment, and it was not close to the towers at all. And he was getting so irritated that he was delayed, right? That delay actually saved his life, right? So, but for him, thinking about it over and over again, he was still affected, right? Is that perseveration. And then the slow thinking, intrusive images, what trauma survivors will call flashbacks, right? Those are all fairly common. And then sometimes too many thoughts at once. You just can't separate your thoughts. Behavioral reactions. So angry outbursts, irritability, fear of being alone, clingy. This happens especially with children. Children's reactions, by the way, are a whole different story because they developmentally really struggle to process. Changes in sexual activity, relational conflicts, all this is very, very common, okay? Just having a hard time talking to people who may not have experienced what you experienced, right? It just becomes a real struggle, especially if you were the one right at the front line. How do you, again, soldiers have a hard time with this, coming back and talking about what they saw or what they may have done in combat, because it's a reality that you can't describe to someone who has not been in combat, right? Then spiritual reactions, meaning just a loss in faith. Like, why did this happen to me? Why of all people was I chosen to experience this? And life feels unfair. Life feels unfair is a spiritual reaction. Spiritual doubt. Some people begin to go to church or temple or, whatever worship they may have more often after a trauma. Other people may decide, I'm not going at all, right? Again, very normal reaction. Seeing life as meaningless, sense of the world being changed, and withdrawal. I have mentioned that before, okay? So the long-term reactions to trauma are many. Now there will be all those other reactions. If you don't get help, they become entrenched, right? So for example, depression can be something that then becomes pervasive, right, and long-term. Reconstruction takes a long time. 17 years is not enough, okay? It can be a very, very, very long time. And it's okay, right? Don't judge it. It's okay to take a long time because something really bad happened.
Can I ask a question?
Yes.
So, 9/11 is unprecedented, so I won't use that as a model, but I'm assuming you do law enforcement military?
I'm sorry?
You treat law enforcement and military?
Not much.
Not much.
Because, they like to go to the VA.
So, a professional opinion then?
Right.
People that would come to you, they've already have been diagnosed. Don't you think that in the medical field, or the World Trade Center Health Program, that we wait too long for these people to have all these symptoms, where if we got to them sooner, then it would be a lot easier to treat them?
But they have to be ready.
They have to do what?
They have to be ready. They have to be ready
Well,
to
I think if you have that dialogue and that rhetoric and that literature, like everything else in this world that's in your face, that you can, that's tangible, that person can read, see, hear, watch, whatever, that it would be a lot easier for these men and women, uniform, non-uniform, to cope
Right.
with their post-traumatic or depression or anxiety or whatever. I think a lot of times we wait too long.
Right. So, to your point, it is a good point. So remember I mentioned the community crisis response team earlier? That's the work we used to do. In the immediate aftermath, we would go into the community, work with the individuals, tell them about all this. Not everyone needs help. You cannot make that assumption. But telling them about all of this is very helpful. This is psychoeducational. This is an intervention in itself. And then if the person wants to follow up and get some help, then it works beautifully because they're coming in as an informed consumer, as it were, of mental health. Do you see what I'm saying?
Right?
Yeah. So that was a really good model to use. It's still around in Massachusetts. But informing, because most people are confused by all this and they don't know and they try to cope in different ways. But when you tell them this is what's going on, they go, oh, okay, right? And then they can decide what they want to do. The reason I said about time, I see an array of people, right? For example, there's a woman I see now who's in her late 50s, right? And she had a trauma when she was 8 years old. Never talked about it. I was the first person that she told about it when she's 59. So she didn't know how to say it. And that's what I mean by they have to be ready. I'm thinking of her especially. With the military and police officers, they tend to go to their own because they like to talk to someone who can really understand, what they went through. And that makes sense to me, right? Although some people, when in retirement, they do come to me, but not when they...
But those entities don't show the compassion and the softness and humanity or what that individual needs, because they are an entity that continues to produce numbers so they can go out there and get their job done.
I can't agree with you more. Absolutely.
We have a question.
Absolutely.
We have 5.
Yeah, I wanted to point out the gentleman over there has a question.
You say, they have to be ready. Okay, I was ready. I was diagnosed PTSD with conversion disorder by a neuropsychiatrist. I went to the World Trade Center program for help, and I was told my night terrors, maybe they're not really night terrors, because I was beating my wife up in my sleep because of night terrors. I was told, maybe you're just mad at your wife.
Yep.
That's what I was told. So how do we change this? I don't fit into every category on there. I was a first responder on 9/11. I was a nurse. I know how to cope with things.
Right.
So I coped with a lot of my stuff. And whether they were healthy coping mechanisms or not, I was coping with them.
Right.
But when I get told something like that,
That's poor training. A lot of people do trauma work and they're not trained to do trauma work. That's a big issue for me. Yeah. Sorry to hear that. Okay. Mary says I have 5 minutes.
Mary, cut us some slack. Let her answer the question.
Okay.
Come on.
I just wanted to speak to what John was saying, and I honestly don't think things are going to change until you can find a different way to do it outside of insurance and documentation.
Right. Right.
Cops and firemen don't want things documented.
Right. Right.
And so unless it's a proactive program where, you just go in and agree to talk to whoever without, writing extensive notes and without looking for a diagnosis to get reimbursed from insurance. It's instead of being reactive, being proactive.
Right, exactly. And that's why I love the crisis team work, because we didn't keep notes. It was VOCA funded. We were getting money. We didn't have to bill insurance, right? We kept numbers, how many people we saw, but no names and all of that.
Actually, Mom was just a general statement. But, to let you get back to going. And I said this, yesterday I say this all the time. Whether it's for the World Trade Center Health Program, for medical, mental health disabilities, even with NIAS and I'm doing outreach, human beings react better to each other. Whether you're helping somebody or you're having dialogue with intimacy. And we as human beings in many fields, we have lost the intimate touch to be able to connect with somebody. And if that's done at the early stages, people will be in a lot better place than we are today. That's all I'm saying.
Another good point. No wonder you're a brilliant advocate for mental health. Okay, so long-term reactions, I went through this. Oh, one of the things, again, John had mentioned a lot about anniversaries. Anniversaries bring it all back again, right? But remember, when it brings it back, it doesn't bring it back exactly as it happened. People do make progress forward. The human condition is such that we do heal to some extent. I mentioned all of that. The brain and trauma, right? There's a little almond-shaped amygdala centered in our brain that triggers alarm reaction, right? And there's 3 usually. Fight, flight, and we added freeze because a lot of women actually freeze. They don't fight or fly or run away. So freeze was added to that. When something, again, 9/11, there was no filing and thinking center for what happened. It had never happened like that before, right? So we couldn't understand it, okay? Triggers remind us, they set off the alarm reaction, and sometimes when that gets set off, it's just like, a fire. The alarm goes off and it starts a whole cascade of events. Factors that affect recovery is the event itself, right? We cannot ever forget 9/11 because it was too big of a tragedy, right? The environment you're in can affect your recovery. The network of support validates, normalizes the individual and the stage, person's developmental stage, like I said, children hard to process, and someone's past trauma history, right? If someone has already had loss in their lives and then they go, through another major trauma, it just piles up. Yeah, and it never goes away. You always carry the wounds of your loss and traumas. What helps? The strongest empirical support is for individual trauma. Again, John had mentioned the intimacy. It's in the individual psychotherapy that intimate environment can be created. Trauma focus, the gentleman left the room, but that's what's important. Many clinicians are trained to be clinicians, but not trauma-focused clinicians, so that's why they say things the way they say it, okay? There's many different models of psychotherapy, and I just wanted to quickly go through this so that you can, again, be informed consumers of psychotherapy. Very important, once you connect with the psychotherapist, to make sure that there's a match between you and the person, right? It's okay to leave someone and find another clinician, right? People need to be empowered to do that. When I first meet with someone, I always tell them, let's have this first session, let's see if we click, right? And I do psychoeducation about what click means, because you don't have to start with someone you get assigned to. So safety and support is the beginning stages. I've worked with people, we would do a group, safety and support group. People would be years in that group, and that's okay, because just feeling safe, remember all those reactions I mentioned, just feeling safe can be really hard. And then working through, processing the trauma, getting feedback, normalizing, and only then you reconnect and you have commonality. The goals of therapy are to transform the traumatic memory into a snapshot, right? Meaning it's not overwhelming you, but it's now, just there tucked away like a photograph. The survivor always determines how much will be uncovered. Right? I've seen people for sexual abuse, rape, and so on. They think the minute they come in to see me that they have to tell me exactly about what happened. And I always reassure them right from the beginning, you know what happened, there's no need for me to know. If you think there's a need for me to know, I'm willing to be the receptacle for it. But my own curiosity should not dominate knowing what happened to someone, okay? And the full memory may include 5 senses, but there are some things that people may not be able to remember. Outcomes of therapy, people will say they have a new self, they feel more confident, they're feeling so much better, right? They move from always watching and monitoring, that hypervigilance, to now just a full awareness of the environment, internal and external. And then an exploration of the inner landscape, always being very aware of what I'm feeling and how I'm reacting. Those are really important. The survivor mission and social action, clearly both of you are very, very involved in that, right? That's a higher outcome of processing trauma and the commonality that you feel in doing that work. So kudos to both of you. And other people in the room who are doing very similar work. It's great work, and thank you. And then CBT, people have heard about, right? Cognitive behavior therapy. My issue with CBT is it helps with the symptoms, but it doesn't get to the root cause. So even though I'm a trained CBT therapist, I use it just to manage symptoms, right? To manage people's behaviors, and then we look at deeper why it came up in the first place. Yes?
Yeah, I do CBT, cognitive behavioral therapy. How does that compare to talk therapy?
It is talk therapy, but your focus is on changing someone's behavior. Like if someone's not sleeping, right? You teach them how they can sleep better, like do sleep hygiene. You're going to do this before you sleep. You do that, take a shower, all those kind of things. Or if someone's ruminating, you have them keep a chart of When do you ruminate? Why? How can you cope? That's what it is. Good question. Okay, and there's other CBT in the military. They use prolonged exposure a lot, where they take the person exactly back to where they. 5 more minutes, Mary? We're over.
I should add.
Yeah. We probably won't have time for questions. People have asked questions
they've
anyway.
asked,
Yeah. So prolonged exposure is one that the military likes. I don't like it because you earlier heard me say I don't need to know the full story. But the military does because they think that, and there's lots of evidence, research evidence that it works, right, for people in the military again. These are all just very fancy modalities. Eye movement desensitization. People heard of that, where they wave the finger in front of your eye? Yeah. Again, that's another one that I've been trained in, but I don't use. Right? When you're a CBT person, you usually get trained in that as well. You're asking why? Yeah. Because eye movement, EMDR, usually works with people with one trauma, like only one thing. Yeah. I mean, it's open to debate, but I have found it doesn't work because many of the people I see have complex trauma. They have repeated trauma. So when I'm doing the EMDR, I have a very hard time telling them which trauma are you going to focus on. Okay?
So can you discern between a person who has only one trauma and who has multiple trauma?
Oh, yeah. Yeah. You get that from their history. Right? Mindfulness and self-compassion, and I'm going to end there. Okay? Very, very important. It's important for people to be compassionate about, give yourself a break. Okay? And this is a new area of research now, where they're finding that being self-compassionate and mindfulness can be very self-healing. Okay, thank you.
Oh, thank you.